approach in a patient with an ocular disease. So let's imagine that you're working, practicing ophthalmologist, you have a practice, and a patient comes to your practice, and what should you do to correctly evaluate your patient? So, unfortunately, these days, when we are working so hard and we have so many patients, many times, as I said, unfortunately, we forget to talk with our patients, and putting down a correct and thorough anamnesis is very, very important. So you should learn to listen to your patient. Many times, the correct anamnesis and the correct approach to the anamnesis of the patients and his or her complaints can help you to work out your differential diagnosis, to find the correct diagnosis, and to start an adequate treatment. So, no matter what kind of specialist you're going to become, you must never forget the anamnesis. It's very important. So, when the patient comes into your practice, first of all, you should listen to his complaints. In ocular disease, there are a few major complaints of the patient. So the most important one is that, oh, doctor, I cannot see very well, or my vision is not so good. I cannot see for example, the TV, or I cannot read very well for some time. Or here it's important to ask your patient whether the decreasing in their vision is what is the duration of the decreasing of the vision. So is it for example, for a few months, or it's for a few hours? It's very important, because the second one can be an emergency situation. For example, central retinal artery occlusion, or central retinal vein occlusion, or retinal detachment, or it can be acute glaucoma. So it's very important to ask for the duration of the symptoms. The other one is pain. Of course, you should always ask for what kind is the pain and what is its duration. So there are different conditions that may cause pain to the patients. Of course, trauma. Of course, some types of keratitis, some acute glaucoma, of course, and etc. What is more, there are many subjective complaints like itching, burning, foreign body sensation, that may be typical for very different disease, from dry eye to allergic conjunctivitis from any kind of medication, for example. So many times the complaints can be correlate to different one and the same complaints can correlate with different conditions. So the other one is, of course, epiphora or tearing, watering eye, many conditions like allergic conjunctivitis or viral conjunctivitis may cause excessive tearing. So these are the major complaints. But you should remember that the most important one that bothers the most our patient, that bothers the most our patient, it's the decreasing of the vision. So the other step is you should get information on the past or present eye diseases. It's very important to ask patients if they have any past documents related to any other if he have passed the documents from other ophthalmologists, so you can see the history of the eye condition in your patient. Unfortunately, our patient rarely brings their documentation related to their health condition. But I mean, ask them to come to follow-up visit. When you ask them to come to the follow-up visit, you should always get straight to them and explain them. It's very important to bring any information, any documents related to their present health condition, especially of course related to their ophthalmology status. The anamnesis is very important when we are talking about trauma and injuries. What is the traumatic agent, or if there is a chemical burn, what is the substance that gets into the eye. It's very important about the steps you should perform to eradicate the substance, and what must you do next. Of course, you should ask when was the injury, because unfortunately, of course, it depends on the injury. But for example, for foreign bodies, for corneal foreign bodies, for example, many times our patients come to us, for example, even a week or two after they feel that something gets into their eye. If they get late and if they're too late and if they come too late to us, it may cause very, very bad conditions, and for example, even endophthalmitis, so very keratitis, for example. They can even they can even get endophthalmitis, which is very, very bad condition. So any other comorbidities, any other diseases, systemic diseases like diabetes or arterial hypertension, of course, any disease of the I forgot the word. Thyroid of the thyroid gland. It's very important. Of course, the family history. There are many eye diseases that they're related with the family history, like glaucoma, like macular degeneration, like some of the hereditary retinopathies, and etc. So basically, you should check the function, and after that, you should check the structure. So when you're evaluating the patient, no matter what is his condition, you should always check the function. In the eye disease, this is the visual acuity, and after that, the structure. So if there's some pathological changes in the normal anatomy of the eye. So visual acuity testing. So first of all, of course, there are some differences in that are related to what is the condition of our patient, whether it's the trauma or if the patient comes to us only for prescription of spectacles. But no matter what, you should always first check the visual acuity. In Western literature, in Western Europe, and in America, it's always we talk for best corrected visual acuity. So here in Bulgaria, we should first of all we check the visual acuity without correction of the any refraction anomaly, and after that we write it down, and after that we evaluate the visual acuity with the corrected refraction anomaly. For example, myopia or hyperopia or stigmatism, no matter what. So this is a slide from the presentation of Professor Oscar. So some basic things about the visual acuity, remember them, especially this formula, Donder's formula, that the D is the distance from which the patient can distinguish the object type, and the other D, the distance from which the normal seeing eye can distinguish it. So this is the different system that can be used to measure the visual acuity. The most popular one in the USA, in some of Western countries, is the feed systems. So 2020 is the 100% vision. Here in Bulgaria, we use the decimal notation system. So it's different, but in all these systems, the main principle is based on the Donder's formula. So this is the type. I show you some very important slides, and be aware of them because you can, from them, there can be questions in your final test. So that's why I get them from the presentation, from Professor Oscar's presentation. So here, again, some of the basic things. Angulus minus separability, or minimum angle of resolution. So details can be seen in 1 arc minute, and the whole object in 5 arc minute. This is the basic principle of all the charts that are made for evaluating the visual acuity. So here in our units we have for checking the visual acuity, of course, a chart. There are different charts. Now we have monitors. There are many different other charts. There are plastic charts that can be put on the wall. There are projectors that are projecting the charts from one part of the room to the wall of the other part of the room. Of course, today's charts can be they use soft. any distance from the patient to the chart. So the other thing, of course, this is the trial lens set for evaluating the refraction, trial frame for the patients, and this is the result from refractometry. So the refractometry, I'll get here, right here. So this is refractometer. So this is a computer device that measures the refraction of the patient, so that that can help us to see what is the refraction and to correct the refraction anomaly of the patient. So in order to find the best corrected visual acuity, for example, here this on this printout you can see this is the sphere. This is minus 2.5. This is the cylinder, all the astigmatisms, and this is the axis of the cylinder. So this is the right eye. This is the left eye. So this a few slides with how to evaluate the visual acuity for a patient. So the patient sits comfortably. Of course, this is our patient. This is the monitor in one of our rooms. First of all, of course, we should check the right eye. After that, the left eye. We put a occluder on the eye, in front of the eye. In front of one of the eye and evaluate the other eye. We start with the biggest optotypes. Here it's this is the numbers. There are different kinds of optotypes. Even for children, there are even pictures of different animals or flowers or balls, etc. So we ask our patients if he can see the numbers. If he can see, we come to the other, to the smaller optotypes. Here you can see, so these are the optotypes. Here their numbers, and here it's the visual acuity. It's the nominal system that here we work in Bulgaria, so 0.5, and this one here, it's, let me show you here, this is the feed system. It's the Snellen fraction of this one. So we check the visual acuity. After a few slides, I'll show you how to write down the visual acuity. When the patient when we see, let me show you here. So we write down the last line that patient can see here. So this is without correction of the refractory anomaly. After that, we, depending on the printout of the after refractometry, we put different type of correction. Here, for example, is 0.75 diopter sphere and 0.5 diopter cylinder on the specific degree. And after that, we write down the final value of the visual acuity. So this is for the right eye, this is for the left eye. So let's come back here. So first we finish without correction visual acuity. After that we do it with the specific correction for each patient. Of course, the patient can see 100% without any correction. direction. So if that is the case, we write visus oculi dextri equals 1.0 or 2020. So if our patient cannot see the biggest numbers on the chart, or the biggest optotype, we start asking them to count fingers. And if you can see the steps, we are coming closer and closer to the patient. The other way is to start from the patient and getting away from him. So we ask them to count fingers, and based on the formula, because normal eye can count fingers from 50 meters. So if the patient can count the fingers, for example, from 2 meters, we write 2 and above 50 based on the formula here. Sorry. Up here, so the D, if the patient counts fingers from 2 meters, so we write 2 meters for small d, and for the capital D, we write 50 meters. So in order to change it for a decimal notation, so it becomes 0.04 when it's like this one. So you can see here, so 0.05. So that means that the patient can count your fingers from 2.5 meters. So if the patient cannot count the fingers from very close distance, we try to hand movement in front of the evaluate eye. So if there is the patient can see the movement of our hand, we write this down, and after that we should always check the projection of light of the patient. First in front, whether there is perception of light. If there is a perception of light, we proceed to each direction, so up, down, temperate, nasally. And it's very important how you write down it. So you should counting fingers if you write this down. So counting fingers in front of the eye. If you write counting fingers, you should write, of course, and the distance. For example, from 20 centimeters or 50 centimeters, you should always write it down. So what does PELC mean? So this is perceptio et projectio lucis certa. So there is a normal perception and projection of light. PLC, this means that projectio lucis certa. So the projection of light, it's normal from all directions. So PLI, so projectio lucis incerta. So this means that there is from one of the direction, from one or more of the direction, there is not the patient cannot see the light, and of course this sign means that the eye is blind. Don't forget always to put this line to cross the zero. It's very important. So one other thing, sometimes we should we try, for example, in a patient with cataract, many times the after refractometry cannot be performed. On the printout, there is there is an error print, and we cannot see what is the refraction. Of course, we can try manually to try different lenses, but sometimes we just only want to know whether there is any kind of anatomical pathological changes, or so any structural changes, or the decrease in the vision is due to some refraction anomaly, for example, myopia or astigmatism or hyperopia. So in these cases, you can put the pinhole occluder or stenopaque hole, so to see whether the patient improves the visual acuity when looking through the central, this small pinhole. Here, the principle is that through this pinhole, only the central light beam that do not reflect from the refraction surfaces in the eye. This is the cornea, the lens. So through this pinhole, only the central beam gets through it and reaches the retina. So with the pinhole tool, we can eliminate the influence of any refraction anomaly on the eye. Sometimes, of course, we can check if our patient is wearing glasses, is wearing spectacles. If he's wearing spectacles, we should always check the visual acuity with his correction or with his spectacles, so we can see if his correction is okay, or we should change the diopters of his spectacles. After that, we should always check the ocular motility, especially in children or in patients with, for example, if we suspect any paralysis of some of the muscles of the eye. Okay. So after that, we should evaluate the anterior segment of the eye. Here, we should not. We should always be very. We should always be very strict and exact, and we should not miss any structure. So we should evaluate the eyelids, the eyelashes, the eyelid margins, of course, all parts of the conjunctiva, the cornea, the corneal surface, the transparency of the cornea, of course, the anterior chamber, its transparency, the depth of the anterior chamber, of course, the structure of the iris and the pupil, and if there, so we should check if there are any pathological changes in these structures. Again, we should not miss any of them. We should not underestimate any changes even on the eyelashes or on the margins of the eyelids. So this is a very good educational movie. It's a little bit long. It's around 30 minutes. My advice is to look at it. It's very informative. It's for these 15 minutes you can see very detailed information that would be absolutely enough for you. so if there are any questions in the test, you manage to answer them. So in this video, there is the there is an explanation of the biomicroscope or the slit lamp, what its structure and its basic parts, how to work with it. Together, and in the examination room, I would have shown you all this stuff, but unfortunately, this is the situation. After that, you must check the intraocular pressure of your patient, so you should perform tonometry. There are many types of tonometers, but one thing you must remember that the gold bond amponation tonometry is the gold standard for measuring the intraocular pressure, especially in patients when you are evaluating or following up patients with or suspect or glaucoma suspects. So, gold bond amponation tonometry. Here you can see the device. So. Okay, so this one. So this is one of the types of gold bond tonometry. So this is the part that connects to the slit lamp. This is the measuring prism, the feeder arm, the control weight inserter, the housing of the tonometer, and of course this is the adjusting knob. So let me show you one video for tonometry.
The definition of intraocular pressure is the fluid pressure inside the eye. Elevated intraocular pressures can cause damage to the optic nerve, resulting in visual field impairment. However, patients can also develop glaucoma with pressures of less than 22 millimeters of mercury. There are various ways to measure the intraocular pressure.
So these are the different methods. I would like to show you on
The equipment we need are a single-use applanation prism, a Goldman applanation tonometer, local anaesthetic drops with fluorescein, and the Goldman applanation tonometer calibration.
So basically, there are two main types of tonometers: contact and non-contact. The contact tonometer, the most popular one, is the gold bond amponation tonometer. About the non-contact, these are the so-called airpuff tonometers. So there are pros and cons for each type of tonometer, but of course, when contact tonometers are far more correct and precise, but of course there's always a risk for infection or damaging the cornea. Of course, if you perform correctly measuring the intraocular pressure, there is no risk for the patient. Of course, gold bond tonometry, it's a little bit time consuming, but the airpuff, the non-contact methods, they're faster. not so precise, but they're faster if you have, for example, 50 patients and you have a little time to see them, and if you want to check the intraocular pressure of all of them. Of course, you can use the non-contact tonometers, but when you following up your, for example, glaucoma patients, and you want to see the effect of the therapy for lowering the intraocular pressure, you should always use the golden phonation tonometer.
Insert 0 millimeters of mercury mark. Insert the 0 width.
So this is the calibration.
The prism should tilt back the -2.
It's not
Once
so
the patient has been
important.
called into the area, you should always introduce yourself, check the patient's name and date of birth, which will ensure that you have the correct patient with you.
You should always explain to the patient about when you're measuring the intraocular pressure, or every time when you perform any test that it's related to eye contact. So it's a contact test, because when you explain correctly to the patient, then they can be more. It will be more easy for you to perform the test precisely.
And ensure that they are the patient, so that they are aware that you have done so. It's still
so golden phonation tonometry, like all contact methods, you should perform them with instilling anesthesia. And here, the specific thing in golden tonometry is that you should use fluorescein dye to cover the tear film of the patient.
Oximeter 0.5% and fluorescein 0.25%. One drop to both eyes.
You can use
Explain to the patient that these drops will numb the eye during the measurement.
like drops, or you
Numb
can
the eyes
use
with tissue
strips.
so that they are not too watery, as this can change the bias weight thickness. Ensure that the eyepiece is set to your own prescription. Place the slit lamp height in proportion to the patient's sitting position and head position by using the level under the slit lamp table and adjust to the acquired position. Ask the patient to come towards the slit lamp with their chin sitting on the rest and their head firmly against the head bar. Ensure the patient's eyes are in line with the black alignment marker. This is important for a precise examination. Turn the slit lamp on by using the on and off switch, then turn the black knob to the maximum brightness. Turn the knob which is below the light filter tray anti-clockwise to B with a blue light.
So you should, for performing the Iop measuring with the golden phonation tonometer, you should use the blue filter, and a few seconds, in a few seconds you'll understand why.
Ensure that the light is at its brightest by adjusting the illuminating knob at the base of the swinging arm. The blue slit beam light should be shining on the tonometer head from the temporal side. Use the joystick to move the slit lamp backwards, forwards, sideways and up and down. Ask the patient to look straight ahead with their eyes wide open. Move the tonometer gently and slowly towards the patient's cornea until touching the central surface. If patients are having difficulty in keeping their eyes open, you may assist by gently holding their lids. Avoid pressing on the patient's eyeball, as this can give a falsely high IOP reading. Eyes are visible.
So this is the arcs you can see during measuring the intraocular pressure with global inclination tonometry. So you can see this picture when the prism is touching the anterior surface of the anterior corneal surface. So what is the main rule? So these are the incorrect positioning of the semicircular mirrors. You can see, so the main rule is that so these all are incorrect, and the measuring the intraocular pressure will not be correct if you see in this way the arcs, these semicircular mirrors. So the correct position is like this one.
To ensure a correct reading, the mire should be of the precise width. Turn the measuring knob until the mires are just touching. At this point, you can record the Iop Method.
So this is when the inner edges of the mires are touching. You can change the position of the mires so that the both inner lines get one to each other with the knob, and when the mires become to their correct position, you can see what is showed on the knob. So here, for example, this is 10 millimeters of mercury. So 12, 40. So this is 15 millimeters mercury. Again, this is what we can see during this examination. So so these are some other very good educational videos. Take a picture of them and check them. They're very good. So the other one, oh sorry, this is Bulgarian language. So this is gonioscopy. This is a very special test that you evaluate using a special gonioscopy prism for evaluating the structure of the anterior chamber angle. This is the angle that is made of the iris and the corneal. Irido, also it's called iridocorneal angle. These are the main structures there. So you should know very good the anatomy of the angles, because there always a question about the anterior chamber angle. It's very important structure because through the anterior chamber angle, so there are located the main channels from where the aqueous humor gets through, and from the here. So it's important for the circulation of the aqueous humor. If there is a problem and obstruction of the anterior chamber, there is a rise of the intraocular pressure. It's well-known fact that pathological changes in the normal structure of the anterior chamber angle can cause intraocular pressure elevation. So after we have finished with the anterior segment, we should check the posterior segment of the eye. Of course, you should remember that you should always do that with pupils dilated, so that you can get very detailed information about the structure in the posterior part of the eye. Of course, on the border of the posterior and anterior segment, it's the lens. Evaluate the structure of the lens with both before and after pupil dilating, to see whether there is a cataract, the type of the cataract, whether some other changes, for example, dislocation of the lens, an example after a trauma, or it can be carotid. So that, of course, you should always check the status of the lens. So there are different types of ophthalmoscopy. So this is the how to evaluate the posterior segment. Here, it's so-called fundus biomicroscopy because you use a special lens to see the posterior segment, but you're also using the biomicroscope, which is the basic device, the main device for evaluating the anterior segment. Here is the same, and here I use a special helmet for performing ophthalmoscopy. All these types of ophthalmoscopy are indirect because they're using special lens. For direct ophthalmoscopy, here use a direct ophthalmoscope, and for you and for your final test, it's very important to know which are the basic difference and not only difference, the basic characteristics of both directed and indirect ophthalmoscopy. I've seen that Professor Oscar gave you this table. It's the same like this one. So you should learn that the table. There are always questions about the difference of the direct and indirect ophthalmoscopy in the test. So it's crucial to know what you should evaluate in the posterior part of the eye. Of course, behind the lens is the vitreous body. Always check the transparency of the vitreous body. Sometimes there is change of the there is inflammation there. There can be blood. There can be foreign bodies. Sometimes after trauma, even the lens can be in the vitreous in front of the retina. So, of course, evaluate the vitreous body. But when you see the posterior ball, the posterior segment of the eye, you can see this picture. So this is the right eye, this is the left eye. Anatomically, the optic nerve head is located nasally, and the macular region and the fovea centralis or macula lutea, it's located a little bit temporally. So, as you, I'm absolutely certain that you know that it's the fovea centralis that it's responsible for our central vision, for our best corrected visual acuity. This is the anatomical substrate of our visual acuity. So when you're looking on the retina, on the posterior pole, you should describe its structures. First of all, you should describe the optic nerve head. After that, you should describe the vessels. The darker one and a little bit wider are the veins, and the other one, the thinner and brighter, are the arteries. Here, this is the fovea centralis, and the macular region. It's the whole region between the superior and inferior arcades of the vessels, not only here. So this is the right eye, this is the left eye. Here again, the picture is centered on the optic nerve head. So when you describe the optic nerve head, you should describe whether it's on the level of the retina. So there is no so to describe if there is so the normal optic nerve head, it's lying on the level of the surrounding retina. So there is no edema of the optic nerve head. If there is any level of edema, the optic nerve head and its borders are not so clear, and there is an elevation on the borders of the optic nerve head. So it seems like it's above the retina, not lying on one and the same surface with the surrounding retina. Of course, you should describe where is the position of the vessels, whether it's centrally or it's nasally dislocated. It's very typical when there is a nasally dislocated vessels. It's typical for glaucoma. Glaucoma damage of the optic nerve. So the other thing about the optic nerve head, you should always describe the color of the optic nerve head. Normally it's a little bit pink to bright red, but when there is atrophy of optic nerve head, always it becomes pale or even white in final stages of atrophy. The other thing you should always note is the so-called cut-to-disc ratio. So you should you should compare the diameter of the cup. This is the cup of the optic nerve head to the diameter of the whole optic nerve head. So this is called the cup-to-disc ratio. The bigger cup-to-disc ratio is typical for some diseases, especially for glaucoma. But there is a rule that the bigger optic nerve heads have bigger cups and, of course, higher cup-to-disc ratio. What is more, you should always compare the cup-to-disc ratio of both eyes. In most cases, normally, the cup-to-disc ratio on both eyes should be very close to its values should be close to each other, sometimes even equal. When there is a difference often above 0.2 or 0.3 between the two cup-to-disc ratios, we should always search for some of the typical diseases that may cause this difference. Again, here, so this is the cup. All discs have all optic nerve heads had some layers. Some cupping, because this is a normal finding, but the important one is what is the cup-to-disc ratio, especially when it's above 0.5, and what is the difference between the cup-to-disc ratios on both eyes. So here an example of two of my patients. So this is a right eye, absolutely normal. You can see a very, very small optic, very small cup with cup-to-disc ratio around 0.1, 0.2, centrally located vessels coming into the retina in the optic nerve head, through the optic nerve head. So it's absolutely normal. You can see it's absolutely normal color of the optic nerve head. Here is a patient with advanced glaucoma, you can see how pale is the optic nerve head. Nasally that is located. You can not see even some of the vessels from the central beam of some of the central vessels of the optic nerve head. They're hiding. They're like hiding nasally. You can see this is a very, very advanced damage from glaucoma. So this is sorry. So this is a typical finding, and it's for advanced glaucoma, and it's the excavation. It's 1.0 here. So the other thing, as I told you, to describe the vessels, whether their direction is correct or their direction they can be tortuous. Of course, there can be a stop in the normal blood flow as you and from embo or thrombosis, and after the stop, the specific vessel looks empty, and the retina, especially if it's artery, becomes white and pale. It's ischemic retina, or there can be even edema on the surrounding retina when it's there is a thrombosis or any kind of obstruction of the flow in the veins. When you're talking about the macular region, you should always check there is a normal light reflex from foveus centralis when you're performing the Ophthalmoscopy. But in different pathological conditions, you can find there is edema in the foveal region, or even the whole macular region, example in diabetic retinopathy, or there can be epiretinal membrane with traction on. It looks like there is a traction on the macular region, and which change the normal direction of the vessels. There can be age-related macular degenerations with their typical findings. You talk for all these conditions with different lectures, but you must not miss even the smallest detail when you're evaluating any part of the eye. Of course, you should evaluate in the peripheral part of the retina. It's performed using the same lens here for gonioscopy. One of the mirrors, actually two of the mirrors are used for evaluating the peripheral part of the retina. Of course, this should be done with pupils dilated. In contrary, gonioscopy, I forgot to tell you that gonioscopy should be performed with pupil not dilated. So, after that, this is the examination of the color vision, the Ishikawa tests and tables. This is for color deficiency conditions. I saw this table on Professor Oscar's presentation. This is the other one that you should learn. This is the typical hereditary disorders of the color vision. There's always a question about this one. So the visual field testing, we're going to have another, I think on the 14th of May, I think, another lecture for visual field testings and diseases of the visual pathways. So then we are going to talk in more details for visual field testing about perimetry and different kind of changes in the peripheral vision, and of course performing the perimetry. And what are the typical findings, normal and abnormal, for different conditions in the perimetry printout. Of course, you should know very well what are the normal field of vision and its borders or limits. Again, there is always a question about the limits of their field of vision. These slides there will be on the other lecture about the visual field testing, and even I can send you or you can take picture of them, because they're very, very informative, and they will definitely help you to learn the anatomy and the basic principles of visual field testing, and the principles for and how to understand what pathological changes, which pathological changes cause any changes in the visual field. Because visual field testing is extremely crucial for evaluating, for following up and diagnosing many conditions, not only related to the eye, but in any pathological changes in the brain. So some of the other diagnostic tests. This is the Behemoth or measuring the central corneal thickness. This test is important for precise measuring and precise measuring of the intraocular pressure, because it's known that, for example, you have a patient, you measure the intraocular pressure, for example, it's 16, but depending on the central corneal thickness, the real pressure might be different. For example, if the corneal thickness is greater, so the cornea is thicker, you measure a false high values of the intraocular pressure. So you should, there's a special table I'll show you on the next slide, how to correct the intraocular pressure related to the central corneal thickness. On the contrary, if it's thinner, if the central corneal thickness, so the central cornea is thinner, the values of the intraocular pressure, they can be falsely lower. So this is the correction table. For example, if it's the intraocular pressure, it's 16, and you measure the central corneal thickness, it's 485. You should add 4 millimeters of mercury to the measured intraocular pressure. It's quite important when you're following up your patients with glaucoma or raised elevated intraocular pressure, and what is the if the therapy, to follow up them to see if the therapy is good enough for your patient, if it's appropriate, or if it's not, and the target values of the intraocular pressure are not reached, you should change the therapy in order to reach them. So ultrasonography, so it's very important test. I think maybe next or sorry, I'm not sure, but we are going to talk about it in a different lecture of one of our professors. But It's a very, very important test, especially in these conditions or this kind of indications of opaque ocular media, for example, corneal glaucoma, Hifema, Hippopion, cataract. So any condition that obstructs the normal transparency of the ocular media, and so you cannot see the structures behind this obstruction. So you cannot see, for example, if the patient has dense cataract, you cannot see the optic nerve yet, you cannot evaluate the posterior pole, the macular region, or if you have hemophthalmos or excessive intraocular hemorrhage, again, you cannot see all the details that are quite important from the posterior pole and retina, the optic nerve and the vessels. Of course, in the intraocular or periocular tumors, any kind of suspected retinal detachment, it's a gold standard for diagnosis of retinal detachment. When we suspect an intraocular tumor, that tumor-induced retinal detachment. In trauma, especially when there we suspect a foreign intraocular foreign body, and one of the very often uses of the ultrasonography, it's the measure of the axial length of the eye, which is one part of the formula that it's for calculating the power of the intraocular lenses that are implanted during cataract surgery. First, in angiography, I only mention it again. Very important diagnostic test. You have a specific lecture and seminar for first in angiography. Very, very important test. It's for maybe more than 60 or 70 years. It's a quite old one, but it doesn't lose its importance for diagnostic many of the conditions, especially of the affecting the posterior pole and the macular region, the optic nerve in the vessels. One of the modern devices that are in today's ophthalmology, we cannot imagine without ophthalmology practice without them. Without it, it's the optical coherence tomography. So it's a basic, not invasive, non-contacted diagnostic method that generates in vivo images of biological tissues. That when it's with so good XR resolution that they are resembling a histological section with less than 10 microns XR resolutions using light for scanning laser. Obviously, these are printouts of from OCT from an OCT of a patient. So this is the absolutely normal macula. So this is the fovea centralis. And these are the different layers of the retina. This is the choroid. These are the vessels and a shadow there, and the shadow from them during the scanning. So there are different protocols in the OCT device for glaucoma, for macular diseases, and etc. So it's a very well equipped with great software, and they're getting more and more sophisticated with daily, almost weekly or monthly update of the software. So these are very good picture of the layers of the retina when that are shown on the with the OCT. It's a very good picture. You can even learn the different layers of the retina with it. And the last one, I would like to talk about the exostomatory. I'm not sure if there is if this one is a part of any other presentation, but I always explain to my students about exostomatory. So this is a way to measure the position of the eyeball corresponding to the margins of the orbit wall. So the normal range is between 12 and 21. Above normal clip, especially for African origins, a little bit higher. And the difference greater than 2, according to someone 3, 4, between the eyes is significant. So this is some cases in children and teenagers. Exophthalmic management increase with age. So I'll show you a short. Sorry.
El siguiente es un video explicativo.
Okay. So
I'm Leon Davis. I am a
So this is the exothermometer. So these are the parts of the exothermometer. Let's show the whole movie. So in Spanish. So these are the exothermometer. This is the exothermometer. So check the what is the external margin of the orbit. This is the correct way to put exothermometer. So you can see here there is a scale. So this is a metric scale in millimeters that show that it's called base, the base. So this is the so this is the distance. This is the distance between the external margins of the orbits of both eyes. So you should put these external margins in here, and after that you can see so here another scale. There are two mirrors, and you should look here. You can see one line, and if I go back a little bit, this is the one line. Up here it's the second one. You should look and then and put it to be right. The black one should be behind the red one, and they both should align to the outermost surface of the cornea. Here. So this is the surface of the cornea, and here, so this is the measurement. So it's 15, 16, 17, 18. 7.5. Okay. After that, we check the other eye. Again, the anterior surface of the cornea. Here's 18. So these are absolutely normal values. They're shown here that there is no difference between the clinically significant difference between the two eyes. After that, of course, there is a patient with difference with difference of the values, with different values on both eyes. So here, this is the distance. It's 109. So the distance, this base, it's very important. This value because this distance doesn't change during after this is a fixed distance. So it's stable because these are the margins of the orbit and both orbits, the external margins of the orbit, so temporal margins of the orbit. So this is a stable value, and it's important for correct measuring can only keep the values of the exostomatory. So it's 20. And here on the other eye, it's 15. So the difference is quite significant. So that's it. I should remember. You should remember. This is, I think, the main take-home message. Do not underestimate any detail in ophthalmology status. But you should remember. You know that there is a guideline for treatment and diagnosis for almost all diseases. But you should try to be to have individual approach to each patient, and so that your approach to be correct, exact, to be precise. You should not miss the details. And the other thing that I think, remember that and use in your future practice, no matter what specialist you're going to be, try to talk to your patient. Don't always hurry. Try to get into their shoes, to understand their complaints, their pain. Be absolutely sure that this will be quite helpful for both of you, and the patient. And if you succeed to make this kind of good relationship with your patient, and when we're talking about this compliance with the patient, you see that you have more and more patients, of course, happy one and satisfied one, and you'll be quite satisfied too. So that's all. Do you have any questions? I hope I wasn't so boring for you in this afternoon. Any question, guys?
Doesn't look like it.
No. I think no.
Okay. So